COVID. And I would like to welcome Professor C.K. Shashidharan sir, Senior Consultant and former HOD Pediatrics, Government Medical College, Calicut, who is going to moderate this session. And today we are having none other than Dr. Jacob John, who is retired Chief of Virology in CMC Vellore, who is both a virologist and a pediatrician and past president of IAP. Welcome, Jacob Johnson, for this gathering. And we are having Dr. Dhanya Dharmapalan, who is Chief of Pediatric Infectious Disease in Apollo Hospital, Mumbai. Welcome, Dr. Dhanya. And we are having Dr. P.P. Jayaraman, who is the President, IAP Kerala. Dr. Vijay Kumar M., who is President-elect IAP Kerala for the next year. And Dr. Narayanan, who is past President of IAP Kerala. We are having senior faculty among us today, Dr. V. Parameswaran, V.K. Parvati Madam, Dr. Shimmi, who was the past Secretary of IAP, M.N. Venkatesan was the past President of IAP, P.S.N. Menon, sir. And I would like to welcome all who have gathered here today. And before moving on to our topic, we all know yesterday we have lost one of our very active member, Dr. Ansari. We would observe 1 minute silence before starting our program. Thank you. Today, as you all know, today we are having two topics. So I would like to invite C.K. Shashidharan sir, who is moderating this session.
Sir, please unmute.
Good evening to all of you. It's a proud privilege bestowed on me just to be part of this evening session with almost all the dignitaries one can imagine. And we have star attraction like Professor Jacob John and Dr. Dhanya as the speakers. To introduce Dr. Jacob John, I think it is very simple because all of us know him very well. He is a pediatrician and virologist and ultimately is a scientist. His contribution doesn't confine to pediatrics alone, but to the entire field of virology and containing the spread of polio infection in the country, and also introducing the measles vaccine for the children, a great thing that he could achieve during his active, even though he is active now, during his yesteryears. And I remember that he happened to be a health advisor to the government of Kerala. And he was given the task of developing the Virology Institute at Alapura when we had the fish disease and all sorts of things. And he identified, he spent so much time in developing it, but that did not come through. That proves the point that the decision-making heads or persons who make decisions in the country should have at least some form of a scientific temper, or the persons who brief them should make sure that they at least understand what they speak. Very few of our administrators throughout the country have this rare quality. We had seen such people in our country who were scientifically advanced even more than the scientists. So I have been a regular follower of Professor Jacob John's writings, which usually comes in Hindu. And all those things which he predicted was proved to be correct in the later years. We don't know how many of the administrators took serious note of that. The spread of virus, he said it is going to the countryside, it is going to have the whole human beings, not only in India, but the whole world. The saddest part of this virus is this virus came in a very dark background. And whoever handles at the administrative level keeps that trait in handling this virus and in handling the human beings all over the world. So we have been warned that we are waiting for the third wave. Let us handle it. We know that we are a country which is totally unprepared to meet any calamity. I am reminded of one of the, in film, MGR was telling, Ponal Pogatum Poda, which coincides with Professor Jacob John. Now he's coming from Tamil Nadu, Vellore. And ladies and gentlemen, it is my pleasure to present Professor Jacob John for the talk. I'll introduce our next speaker subsequently. Thank you very much. Anders, you can.
Sir.
Is it my turn to speak?
Yes, sir.
Oh, I see. Okay, all right. Well, Dr. Shashidharan and friends, thank you for that flowery introduction. The topic, as you all know, is the third wave. Mohandas, will you, who is the?
I'll be doing the slideshow.
Okay, well, please do. Okay, I mean, there are a lot of conversation, media attention on third wave. So is it actually a prediction or a mere speculation? Next slide. Let's look at the first wave. This is a bar graph taken from Worldometer, daily cases in India. And the y-axis is in thousands, 25,000, 50,000, 75,000, 100,000. It didn't reach quite 100,000 daily numbers. You will see every Monday there's a dip because the test numbers on Sunday is lower than during the rest of the week. It's like a mountain. It slow climb to the top and slow descent on the right side. Next slide. Now, epidemiologists use the expressions of R0 and RE or R effective. Basic reproduction number R0 is the average number of average number of people infected by one source person if all in contact were non-immune. That doesn't happen in nature except in the beginning of a pandemic. After many are infected, the real life situation is effective reproduction number, RE. The average has got to be on a long term 1. One infected person results in one infected person, results in one infected person. That's how the infection survives in the community at an endemic level with ups and downs, maybe seasonal. The determinants of RE are infectiousness of virus, which is measured by R0. R0 actually is in all other situations other than pandemic, is a derived number calculated based on experiments or specific community studies. So higher the R0, higher the infectiousness. Lower the R0, lower the infectiousness. For an epidemic, it has got to be above 1. Otherwise, it will not cause an epidemic. So that is one determinant. The other is proportion of immune persons in the community, which is called herd immunity or population immunity. RE more than 1, acceleration ascending slope. Right at the top for a few days, RE may be 1 as acceleration stops. RE less than 1 during deceleration, and RE about 1 during endemic state. Next slide. So you look at the first wave again, ascending limb, peak, descending limb, and look at the base. It's starting, actually it started in Kerala, as you all know, on January 1, but the actual epidemic started only in the second week of March. Numbers are too small because the scale is in thousands. Next slide. The attributes of the first wave, it's rather symmetrical or bell-shaped. The normal distribution of any natural epidemic, bell-shaped. It started on 6/3/20, peaked on 16/9/20 in 191 days. If you look at the total of the pre-peak cases, it was 5,115,893 or average 26,785 per day. It's only an average. Post-peak, 5,108 cases, 49,000 per day. Look at the pre-peak per day and the post-peak per day. It's always like that. The post-peak, although it's good news, I'll show it to you in the second wave also. So the first wave, the post-peak ended in 101 days. So the whole wave took 295 days or more than 42 weeks or approximately 10 months. Total cases, more than 10 million. Average 35,000 per day, 1 million cases per month during the epidemic phase. Next slide. Look at UK epidemic profile. Look at the first wave. During January, February of 20, there was a small hill. There was a lot of news on UK at the time. Look at the scale, 20,000, 40,000, 50,000, 80,000. Then that endemic lull. Then the second wave, which actually is a biphasic wave. If you want to call it two waves, no problem. Wave is not actually defined properly. So what you see visually, you can say it's a wave. Next slide. First wave lasted only 3 months. Drastic measures flattened the curve. It transitioned into endemic phase RE1 and it remained so 3 months. Second wave biphasic, and the total duration of the second wave was 8 months. The second wave was due to new variants. Alpha variant from September 2020, beta October, gamma December, and the Delta variant detected in India from December 2020 in UK. Next slide. Italy, replica. Therefore, same epidemiological factors. Very short first wave, 3 months, long endemic period, then the second wave biphasic. Next slide. Okay, next slide. USA doesn't fit into either pattern. Started early in 2020, and then it has appeared as though it is 1, 2, 3 waves and not yet reached endemicity. So each country, depending upon what interventions are made and its successors, will have its own epidemic profile. That's the point I want to drive home. Next slide. So India's 2 waves. Just have a visual look at it. Next slide. The endemic stage that you saw between the 2 waves was approximately from 28/12/2020 to 9/3/21, 71 days or about 10 weeks. 1 million cases. Daily average 14,364. Okay. 1 million per 10 weeks. Previously, it was 1 million per month. During epidemic, it was 1 million per 4 weeks. Now it is 1 million in 10 weeks at the endemic phase. Okay, next slide. Again, looking at the second wave. Next slide. The second wave, pre-peak profile. We have not seen the end of the second wave, but we are comparing the pre-peak first wave, pre-peak second wave. Second wave started approximately 9/3/21, peaked on 6/5/21. Can you go back to the previous slide? You can see the peak very clearly. The largest, the height was one particular day, 6th of May. Next slide. Okay. Cases till peak, second peak, was 10 million, more than the total of the first peak, or 1,76,000 per day. So the surge volume of the second peak, 1,76,000 per day, divided by 26,000 per day of the second wave, it is 6.6 times was the surge speed of the second wave. Surge speed in days, 191 days for pre-peak first wave, 58 days for second wave, so 3.3 times faster. 1 million cases in 4 weeks, 1 million for 6 days. Time to reach 1 million, 5 times as fast as the first wave. Next slide. Why did second wave emerge? A wave requires sufficient susceptible population. How many people were infected in the first wave? We don't have a good measure. There have been 3 antibody surveys, but there are problems with the antibody surveys. Antibody surveys are not a good way to measure exact antibody profile, because in 2 particular tests, they use 2 entirely different antigens for testing, so they are not comparable. So I'm underplaying the sero surveys, and a sero survey made by the Bharat Biotech company for their phase 3 trial did not tally with the ICMR sero surveys. So I'm ignoring the sero surveys and trying to calculate the number of people infected. For that natural epidemic to peak and come down the way you saw, it's an unmodified natural wave, which means the required herd immunity threshold was reached at the end of 10 months, and half of it was reached at the peak of the epidemic. Okay, so I'm saying the upper limit of the leftover, the lower limit of the leftover is 700 million. Plus, we have 65,000 babies born every day in the country. Compared to the million, this is minuscule, but it adds up per year as 25 million. So in 10 weeks, 5 million children are added during that endemic phase. Variants with greater R0 emerge unnoticed. Difference between UK, they noticed their alpha variant right away as the wave went up. And we failed to vaccinate at least 20-30% of the population before we had the second wave. That is in March. Our vaccine was ready in 2020. It was approved for emergency use on 3rd of January. If vaccine had been rolled out in the first week of January, first dose, first week of February, second dose, first week of March, we would have covered 20-30% of population. At the same time, for various reasons, political and religious, crowding was actually, I'm using the word encouraged. There was no intention, purpose in discouraging crowding. There will be Kumbh Mela or elections, etc. Next slide. So I said 40-50% of the population was vulnerable after the first wave. Left with that particular variant D614G, there would not have been a second wave, but new variants emerged. There is a group of 10 labs assigned for monitoring 5% of viruses, looking for genomic variants, but they did not do their job. Entry of alpha, beta, gamma variants were unnoticed until second wave emerged. Indian mutants, Delta and Kappa, spread fast in Maharashtra and West Bengal. All these were actually detected only after the second wave took off. So there was no warning during the lull period that we are getting new variants. Some of them are known to be highly infectious. Their R0 is higher than the R0 of D614G. Therefore, watch out. That message did not reach us. That is part of the reason why crowds were not discouraged. Okay, next slide. The other hype about the second wave is children were affected more frequently. So where children targeted by second wave, Tanya will probably address that issue. The R0 of D614G is about 1.5 to 2. R0 of Delta is probably 4. No specific study, but the epidemic profile agrees that R0 of Delta is much higher than R0 of 614G, the variant of the first wave. Now, in the first wave, we know people have done studies that in family secondary infection rate was 30%. If you have a family of 10 people, one person got infected, family lives in one household, only 3 of them got infected, or 4 of them got infected. All the rest escaped. Why? Infectiousness was not very high for that particular variant. And also people knew how to take precautions. Whereas in the second wave, anecdotally, I've asked many people, they say the second wave in family secondary infection rate was 100%. If there is a family of 10, one person got infected and brought it home, all 10 got infected in due course. Okay, that alone is sufficient for increased child risk of infection, therefore disease in the second wave. So it is a question of sheer magnitude of infection reflected by disease on a broader age range. Next slide. Will there be a third wave? Next slide. It's a mere speculation. Who speculated? I don't want to identify the person or the persons who speculated the third wave. They had failed to predict the second wave. And so they simply diverted attention of everybody by saying third wave, third wave. However, anticipation and steps for mitigation is good. And I'll tell you why. In Tamil Nadu, they are now planning to have district by district review to make sure that the healthcare infrastructure is strengthened in each district. They don't believe that there's going to be a third wave. However, using that hype, they want to improve healthcare infrastructure. Bed strength in primary health centers and community health centers, look at staff, look at equipment, look at oxygen supply, all these kind of things they are now looking at through NHM. Now, what is the time to predict a third wave? You don't predict the gender of a baby before the wife is pregnant. What guarantee is there that she's going to be pregnant? And when she gets pregnant, it's a very reasonably safe gambling. It's 50-50. Going to be either a boy or a girl. So you can't be very wrong. But the third wave, the wrong time to predict during the second wave, the prediction can only come during that lull period following the second wave, and with epidemiological studies looking for any risk factor that will cause a third wave. And that requires good studies of genomic analysis of the virus. And I don't know whether a new variant can have R0 of more than 4. Okay. So the third wave has low probability, more like 1090. I'm not saying it will not happen, but I'm saying it will be, the probability is quite low. Next slide. We have no precedents to go by. Influenza pandemic are some help. They're different viruses. The 1918 pandemic, H1N1, came in 4 waves. Not every country had 4 waves. Globally, there are 4 waves. The second wave was the worst, with more mortality than the first wave, both magnitude and mortality. The 1956-57 H2N2 pandemic, I was doing internship in Trivandrum Medical College at the time. I got flu. I was admitted. That had two waves. India had documented two waves. 1968 pandemic of H3N2, how many waves? Nobody knew, nobody studied, nobody was interested. It's only flu. The 2009 pandemic H1N1 had two waves. The second wave was not as big as the first wave. But SARS-CoV-2 is different from influenza. So really no precedent to go by. But it's good to anticipate. Next slide. India's population is 1,400 million. Next slide. The first wave was due to Wuhan, the founder variant, Wuhan virus 1, and then D614G. Second wave was due to alpha, beta, gamma, delta, kappa variants. In 10 weeks, 7-day rolling average was less than 15,000. That is the lull period I'm talking about. So I'm predicting there will be a post-second wave lull for sure. Will need to be alert or anxious according to your personality only during that time, after seeing what's happening. Urgent genome surveillance is needed, and only faster spreading variants can cause a third wave. Next slide. Herd immunity. First wave infected conservatively 40%, more liberally 50%. That means 560 to 700 million people got infected the first wave. The balance, 700 to 840 million left. The second wave would have infected 75% of the balance because R0 was about 4. So we can calculate based on that. That means about 500 to 600 million people got infected in the second wave. So the total immune today, or at the end of the second wave, will be about 1,000 to 1,300 million people. The balance left is only 70 to 300 million people. Not enough for a wave. You may have a small ripple, but not enough to have a wave like the second wave, in which the population base was 700 to 800 million. Next slide. Who is in charge? Is the virus in charge or we in charge? If the virus is allowed to decide, the virus will do what it wanted to do. If we are allowed to decide, we can vaccinate people. If we vaccinate 20% of the people with 2 doses, by end of August, even the remotest possibility of a third wave can be avoided, because the herd immunity is topped up by vaccination. So now is the time to investigate whether a third booster is good for Indians or not. Why third booster? If you hyperimmunize, there is a tendency for broadening the affinity of the antibodies. Of course, cell-mediated immunity will also be boosted. And if you broaden the affinity, the cross-reactive protection will also go to variants. So that is something that India must study. But we don't have enough vaccine for covering 20% with 2 doses. So the third dose idea is wishful thinking. But fortunately, Bharat Biotech is actually now studying the advantage of a third dose. Next slide. Thank you very much for a patient listening. Thank you very much. You can turn the slides off.
Thank you, sir, for that nice descriptive talk. We will postpone the question answer session at the end of the talk by Dr. Dhanya. Dr. Dhanya is, as it was mentioned by Professor Jacob John, the rising star. She's the youngest publisher and editor of pediatric textbooks and co-authored and edited so many books in pediatrics. She's head of the infectious disease department in Apollo Hospital, Mumbai. And we look forward her deliberations on the pediatric COVID-19 and insight. I invite Dr. Dhanya for the talk. Thank you.
Thank you very much for the kind introduction. Thank you, IIP Kerala and IIP Kozhikode for inviting me. It is a great honor for me to share the platform with Professor Jacob John sir, who is also my mentor. So thank you. Today, I shall be exclusively speaking on pediatric COVID-19. Can you see my slides?
You can see. You can see. Yes, we'll see.
So, since past few weeks, we have come across these various headlines about the speculation of a third wave hitting children hard. And the administration has also geared up in preparations to tackle the third wave, especially in children. Maharashtra was the first state to set up a pediatric task force. Many states have already set up teams. Now, at the same time, in the same period, we also have come across statements from the Indian Academy of Pediatrics that there is no scientific evidence yet that the third wave will severely affect children. And so did the central government release such a statement. Now, tonight, I'm not here to basically speculate about the third wave, but I would like to present what data is available to us in our hands now. So before I do that, let us return to basics. So we all know COVID-19 is caused by SARS coronavirus 2, which requires binding with the ACE receptors. And fortunately, the expression of these receptors are less in children in the lungs compared to adults. Therefore, they are spared from the severe lung disease that we see in adults. However, children do carry high viral loads in the upper respiratory tract, and therefore they are very good transmitters of the infection in the community. By and large, over 95% are asymptomatic or mild, up to 5% moderate, and less than 1% severe. And the severity is more in children with comorbid conditions like chronic renal disease, chronic heart disease, chronic or some blood disorders, immune suppressed, obese or severe malnourished children. Now, this is Mumbai data. The source is the BMC COVID dashboard. And you can see that this is a very latest one dated June 4, that is just few days back. And if you look at this data, you have total positives, about 7 lakhs. And please look at the left corner. So you can see the age groups here. So 0 to 9, 10 to 19. So they represent the pediatric age group. You add them up and divide by the total positives. And you get a percentage about 6%. So we know that till date, children have contributed to about 6% of the total COVID cases. We also have deaths in children, which are marked in these red circles, 26 deaths, 0 to 9, 45 deaths between 10 to 19. You add them up. So there have been 71 deaths in Mumbai. And if you look at the mortality by dividing by the total deaths, you get around 0.47%. Now, unfortunately, we do not have a detailed analysis of these deaths, whether they have occurred in comorbid children, or have there been any healthy child, or have they been MIC cases which have tested COVID positive. Now, fortunately, I also have a screenshot which I had taken in the month of September. So we saw in the previous SIRS lecture, September, it was around the peak of the first wave. And if you again do the same exercise of calculating the numbers and dividing, you get a percentage of about 5.46. So 5.5%, 6%, not a big difference, right? So this is very much in line with the pan-India data that ICMR released last month. And it stated that in the first wave, about 4.2% children had contributed to total COVID. And in the second wave, it was around 5.8%. So again, not a very big difference, a marginal increase. Now let us come to individual states. So I could find the COVID dashboard data of Uttarakhand giving the 8 specific numbers. And after doing the same exercise, found that there was 9% contribution by children for total cases. Karnataka was a bit higher at 11.3%. I have picked up from the media reports and used Arogya Setu for the denominator for this. Andhra Pradesh, this is between May 18th and May 31st. Karnataka was past 2 months. So Andhra Pradesh is between May 18 and May 31. And the percentage came out to be roughly 10%. Now, so you know roughly that it's in the second wave, probably between 6% to 11% was the contribution of children to COVID cases. Now let us look further, closer. And I'm sure most of you have come across this going viral on WhatsApp and in media, other media. So in Maharashtra, district, Ahmednagar had recorded over 8,000 children as COVID positive, and the media had already sensationalized this issue with pictures of the wave, as if the wave is coming, the third wave, to drown these children. So if you look again closely at the report, you will find that over 95% children actually did not have any symptoms. So they were basically tested as part of contact tracing. And Sir has already explained about the 100% transmission that has occurred in the household, the secondary attack rate being 100%. And this was again confirmed by the state health officer that over about 95% of these children had no symptoms. Therefore, please not to be alarmed by the figure. And this is the situation across the country. The problem is the media gives just the absolute numbers, and that itself creates panic. We understand by simple epidemiology that we need to look at percentage. As the total numbers go up, the proportion, the numbers in children also go up. And this is beautifully depicted in the US graph. So this is the source is American Academy of Pediatrics, and they have meticulously recorded the COVID cases every week. And the light blue represent adult cases, the dark represent the pediatric cases. And you see that as the cases go up in adults, so do the number of cases in children. Now, US has the largest data in the world in pediatric COVID, about 3.9 million cases. As per their data, the pediatric population had contributed to 14% of the total number of cases. As Sir said, US is already in a post-third wave. Now, if you look at the hospitalization rates, less than 2% have been hospitalized. So it is reassuring that 98% of these COVID infected children have been managed on outpatient basis. And if you look at the percentage that children contributed to the total COVID-19 hospitalization, it was roughly 1.3 to 3.2%. That means that, say, if you have a hospital of 100 beds and for 97 adults admitted, you may have about 3 children admitted. Mortality was 0 to 0.2%. Some states had recorded zero mortality. Now, we would argue that US health infrastructure is one of the best. We cannot compare India with US. Okay, so let us look at the UNICEF data from 17 countries. And this is not updated data because this was at the time when there were 2.4 million deaths. But that also gives a low percent of mortality among children. Then the question comes, then why are so many children in Brazil dying from COVID-19? And actually, probably it is the large number of deaths that occurred in Brazil that probably sparked off the fears that same may happen in India. Brazil, historically, you all may recall in 2008 dengue epidemic, mortality in below 15 years in children had contributed to more than 50% of deaths in Brazil. You all remember the Zika outbreak where thousands of neonates were born with microcephaly. And now Brazil has reported over 0.5% deaths below 10 years. This is much above the global average. Now, if you see, if you recall our BMC data, it was around 0.5% in less than 19 years. Now, this is in a young age group. In Mumbai, it is 0.1%, but here it is 0.5%. Now, out of 800 children who have died, 500 deaths in infants. So, what is killing the infants in Brazil? And all these reports are in media. Unfortunately, there is no scientific analysis available, no statement from Brazil Pediatric Association, no statement from the international organization. And so, but at the same time, we also know that many mothers, pregnant women have died. Over 800, and hundreds of pregnant women, please read it as pregnant women, have died every month. And they have attributed it to an evidence of probably increased, now called gamma strain virulence in pregnant women. So if you again go through the media reports, you see that they are basically talking about high rate of premature births and many deaths that have occurred in pregnant women. And whether this is linked with infant death, we don't know until some scientific report comes out. But we can just, for now, look at what media is saying. And this is the statement of Brazilian epidemiologist who's leading the study on the impact of the variant, who is talking about the higher death rates among pregnant women and some giving birth to stillborn or premature babies infected with the virus. So if you ask what is the lesson that we should learn from Brazil, it is that there is evidence that pregnant women are dying. If you ask your obstetric colleagues today, they will also tell you similar tales of pregnant women having had adverse events during the second wave in India. So the model of this is that we must protect the pregnant women and vaccinate every pregnant woman with COVID vaccine. This itself will help probably to reduce the mortality rate, especially in the neonates. Now, coming to the IAP COVID protocol, April 2021, a new one is being revised. It will be released in few days. If this is a busy slide, and all of you must be having this protocol with you, but I just want to point out that more than 95%, about 98% of your patients just belong to this category, mild disease. And it's fairly simple. You just have to give symptomatic treatment. If there is fever, give paracetamol. If there is loose motion, give ORS. And these are just screenshots of my teleconsultations, because even in my practice, about 98% of the time, these are what complaints are. So a 4-year-old with fever since one day. So this is not to promote any brand, just ask what they have at home and simple symptomatic treatment. If they are on antibiotics, please stop them. There is absolutely no role of any antimicrobials in COVID. Then you also explain the red flag signs. This is another case, an infant who had fever, who stayed in a joint family, and you must give advices such as keep away from grandparents, ask them to wear a mask. The infant can be breastfed with precautions. These advices are very helpful. Now coming to MISC. Now MISC has to be looked differently, because one, it occurs about 3 to 4 weeks after COVID. It may not be caught in active COVID surveillance. Maharashtra has started keeping a registry of MISC. It has become mandatory to notify. MISC can present in shock. It can present as a Kawasaki prototype, or it can present as a mild febrile inflammatory state. Now, this management of MIC requires special setting, and the definitions, criteria, all are very straightforward and clear. I would like your attention to this paper. Please look at the two graphs. This is the world map. A graph represents the COVID cases across the world. So the higher the number, the darker the color. That's why India and US are darkest here. And they have also compared the MIC cases from these countries. US has the highest MIC data. So 4,000 cases have been reported from US. Now, this is out of 3.9 million cases. So MIC is a rare complication, but of course it's a life-threatening complication. Median age being 9 years. We all know Kawasaki usually occurs below 5 years, but this little older age group. And they have studied correlation with race and ethnicity, and they found that 62% were Hispanic or Blacks. Now, if we look at the Asian percentage of MISC in these international studies, we find that in UK studies, they were about 30 to 40%, in France 10%, and US 2%. But very, very surprisingly, countries, Southeast Asian countries such as Japan or China, which actually report high number of cases of Kawasaki disease, actually have reported none. No MIC from China, no MIC from Japan, and only 2 cases from North Korea. So we don't know whether there is any genetic or any racial predisposition for MIC. It is impossible to predict which child may develop MIC. And if we, the IP intensive care chapter has mentioned that over 2,000 cases have been recorded from India of MIC. Now, if you look again at the protocol, you will find that if a severe MIC case comes to your hospital, you require some special investigations which are not available in all hospitals. You require to do 2D echo. You require a pediatric cardiologist to interpret it. And if you look at the management, a patient who comes in shock requires these special medicines. You all know how costly IVIG is. One vial of 100 ml costs 15,000 rupees. So a child weighing 10 kg, the parents have to spend 30,000 rupees only for IVIG. So how will a child coming from a low middle income family setting afford to be treated for MIC in a private sector? And unfortunately, this is the latest report, 2020 report from the government. The public health care is different in different parts of the country. And the norm of community health care center catering to about 1 lakh population. Please note, community health center is where some emergency care is possible, where some specialty service is possible. So that norm is fulfilled only by few states in India, including Kerala. But look at the other states. So here you see green, 1 lakh to 2 lakh, Madhya Pradesh, Rajasthan, Maharashtra worse, 2 to 5 lakhs. And Bihar, it's still worse. So one CHC catering to more than 5 lakh population. So you can just imagine what can happen in these states when you have a single case of MIC to be treated in a public health sector. And especially you have even shortfalls of specialties. And pediatricians, the shortfall for pediatricians is more than 75% in our public health sector. So yes, it is a welcome step that the government is planning to invest in pediatric health care settings. So we must encourage this, and it should be a long-term sustainable effort to later include even non-COVID conditions, because we don't want even a septic child or a child with bacterial meningitis to die because of the illness. Lastly, about the vaccine, there's a ray of hope. Clinical trials have already started. Also, intranasal vaccine is under development that may help in halting the community transmission. Why should children be vaccinated? Children must be vaccinated, though they are not severe sufferers. They are good transmitters of the disease. So vaccination will help in reducing the viral load and ongoing onward transmission. And this will enable safe school attendance too. So to summarize my talk, absolute numbers of COVID-19 must be interpreted as percentage of total population infected. So when you see a media report next time, please look at the percentage infected. But at the same time, children have accounted to 5 to 11% in the second wave, but over 95% continue to have either no symptoms and or are mild. Those with comorbidities need close follow-up. No role of antimicrobials. Vaccination of pregnant women need most urgent attention and would probably reduce the infant mortality. MIC, though rare, is a life-threatening condition which is treatable if detected early. All doctors and staff caring for children need to be trained for timely referral. And these referral centers need special settings, need special trained persons, need special medicines, very expensive in private hospitals. So improving pediatric healthcare services is welcome, but should have long-term plans to cater to non-COVID illness, and vaccination among children would help in reducing community transmission and safe school attendance. Thank you very much.
Thank you, Dr. Dhanya, for an excellent talk and insight into various aspects of childhood COVID infections. And as it has been feared of, the percentage of children infected and becoming affected is practically minimum. But going for the complications of COVID infection, as you mentioned, MASC is certainly an alarming situation faced by most of the pediatricians. I think we can take the questions. Ajay, please.
Yes, sir. So I think the first question is to Dr. Jacob John, sir. Sir, is there a cutoff for IgG for clinical significance? So can you unmute yourself, sir?
You're talking about anti-coronavirus IgG.
Yes, sir, coronavirus IgG.
For what? I mean, the problem with the coronavirus antibody tests are, unless you do virus neutralization test, the antibody tests are not very good, because the commercial antigens are either towards N antigen or RBD antigen or S1 antigen or S2 antigen. So they're not very good. If you want to really look at immunity, of course, cell-mediated immunity is not practical. You must have virus neutralizing antibody. That is not commercially available. So we don't have a good antibody for purposes of individualized antibody measurement.
Sir, Dr. Jagadish Chinnappa, you wanted to ask, sir?
Thank you. Thank you very much for allowing me to speak. I have one question each for Dr. Jacob John and one for Dhanya. Dr. Jacob John, as usual, a fantastic talk. One question I had was, if you look at the data coming in from Israel and from the United States, after covering a majority of the population with vaccination and a large number also affected by their disease in the US, the maximum number of cases now seen are in children. So if the first and second wave in India has covered a large part of our population, we probably are going to see an increase in the number of cases in children, as we are seeing in the second wave now. What are your comments, Dr. Jacob John?
The second wave, unlike the first wave, actually hit children with infection, because under the lockdown, everybody was staying inside homes and children got infected. So we don't know the proportions of leftover susceptible population. However, that may not be big enough for having a wave as such in the community. Will in children infection incidence prevalence go up? It's unpredictable. Subclinical infection, nobody is going to pick up. Only clinical disease people will pick up and prove that it is the COVID. So we will not know, but I can only tell you my gut feeling. Unlikely.
Thank you, sir. Thank you very much. Dr. Dhanya, a couple of points for you. Excellent talk as usual. What is the impact of COVID on malnutrition? Because many of our children in the last 1 year are going to be significantly malnourished for various reasons. And the second question I have for you is, studies in England are showing about 10% of children with even mild COVID going in for long COVID, or symptoms persisting beyond the 4 to 6 weeks of what the average COVID takes place. Now, what about long COVID in children? Are there any studies to look at this problem, which may affect our population too?
Thank you, Dr. Jagdish, for regarding the the first question was about I'm sorry, you have to repeat.
Malnutrition.
Malnutrition, yeah. So we know that severe malnutrition has some degree of immune deficiency, and COVID therefore could be of high risk in these children. And you are absolutely right in pointing out, because of the lockdown, and there are many children who are severely malnourished. So actually only time will tell, but definitely there could be higher risk, just as there is higher risk in obesity, severe malnourished can be. So that's a good point, but we really don't have the data right now, and we'll have to see what happens. But so far, we have not come across severe COVID cases in the present malnourished population. Secondly, regarding the US data, regarding the post-COVID also, unfortunately, I haven't come across publications talking about post-COVID in children lasting for 3 or 4 weeks. Can you tell us about what kind of symptoms were there? Weakness and body pains that you're talking about?
I will just give you a small bit of data which has come in just a couple of days back.
Okay.
And which shows that even children, they have shown about a 10% of children with almost 200 different symptoms. And they have looked at various things. And in fact, the National Institute of Health is putting in about $1.15 billion into this long COVID. And especially about children, they have mentioned that there is also about 10% of children who can go in for this long COVID symptoms. So I think we are dealing with a very, 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 very unique kind of an infection, which is doing too many things.
Right.
You see? So we need to probably, we are in the learning curve. We have learned quite a bit about this disease. And probably over time, we will also know. And for another thing which happens is more diabetes coming up. I don't know what your thing
Yes.
as far as this is concerned.
So we have also seen a few children presenting in diabetic ketoacidosis, and there are few published reports indicating a probable relation. Also, acute appendicitis masquerading as MIT, that is also happening. Post-COVID syndrome, even in the adults, that is still evolving. I mean, we are seeing new things happening in adults. So definitely it is something that needs to be watched for. But even if there is data from US, fortunately, their current data still talks about less number of hospital admissions. So hopefully these are symptoms which probably could be managed. They are not, I mean, in the sense on outpatient basis, and might not require hospitalization. So we need to have more research on what's happening in India.
Thank you. Thank you, Dr. Danya.
Thank you, sir.
Thank you, Dr. Jagadish. So there is one more question from Dr. Mohandas, sir. So to Dr. Jacob John, sir. So the second wave is coming down. Is it whether due to herd immunity due to infection, or because of immunity due to our social distancing and other measures?
The second wave peaked on 6th of May. Till 10th of June, that is in 1 month, do you know how many people had been detected infected? 8 million. Okay, on the upswing, it was little more than 10 million over 2 months. Downswing in 1 month, 8 million. We have to go another 2-3 weeks. So the numbers detected infected are so huge that we have to assume that the shape of the curve, beautifully bell-shaped. The first wave flat but well-shaped. The second wave steep but bell-shaped has got to be driven by natural herd immunity, bringing the epidemic down.
It's Dr. Tarlojan, sir.
Yeah, my question to Dr. Dhanya, as Kawasaki is known to be a disease of rich people and rather coming from affluent families, is there any similar case scenario as far as MISC is concerned? One. The second part is, has anybody looked at some predictable factors? That what were the predisposing or predictable factors where MIC could be predicted?
So unfortunately, we don't know we cannot predict in any child whether that child can develop MISC. And regarding Kawasaki, again, both Kawasaki and MIC seem to have a racial predisposition. So I think studies are ongoing. So that was one first paper that probably indicated some relation. But this is very weird that Kawasaki countries like Japan and China have no reports of MIC. So there is something about racial predisposition. But there is we cannot predict as such in which child we can get MIC.
Let me add something here.
Yes.
Kawasaki disease is global.
Yeah.
It was first described in Japan and then described in Hawaii. During 1974 to 76, I was teaching pediatrics in University of Arizona. The very first case of Kawasaki in continental United States was described by me in the literature.
That's great, sir.
And it was a white child. And also I had followed up some 6 or 7 children. All of them were white children. Whether they came to medical attention and blacks did not, Hispanics did not, I do not know. But all of them were white American children, not from low income group, middle income, average family.
But regarding the relation with economic status of the family, I have not come across, because we have had to make arrangements for so many children for procuring IVIG on donation basis or some social support. So I don't think there is any kind of relation with the social economic status of the family.
So one question from Dr. Abdul Latif, sir. So what's the ideal interval for second dose of vaccine?
That is to me?
Yes, sir. Yes, sir.
Yeah,
For you, sir.
okay. Yeah. There's nothing called ideal, because ideal has not been tested. Each company puts out a vaccine having tested a particular schedule. Pfizer, it's a 3-week interval schedule. Moderna is a 4-week interval schedule. Most other vaccines are 2-dose schedules are 4 weeks interval. Covishield we opened with 4-week interval. Covaxin is 4-week interval. So 4 weeks is standard for all of these vaccines. And if you want early protection, you need to give the second dose as early as you can. And as early as you can is 28th day plus. Okay. So during the middle of an epidemic, the ideal interval is 4 weeks. If you deny protection to senior citizens by delaying the second dose further down, you probably deny the protection. And I know of many people who have died with 1 dose. The second dose time has not come. They get COVID in between, and they don't have sufficient protection against COVID or life-threatening COVID after 2 doses. I can guarantee that death will be prevented in virtually 100% of people who got 2 doses, and 2 weeks later, it's a life-saving situation for both these vaccines. So in the middle of the second wave, 4 weeks is ideal. Beyond the second wave, when during the lull period, 12 weeks is okay because you get more mileage for the second dose with 12 weeks. Between 4 weeks and 12 weeks, it's a linear relationship. 6 weeks or 8 weeks or 10 weeks or 12 weeks, you get slightly better protection rate. But even at 4 weeks, protection against death is virtually 100%. Thank you.
Sir, Vijay Evalis, sir, past president of IAP. Sir.
Good evening and thank you so much, sir. It's a treat listening to you. And thank you, Dhanya, for an excellent talk. I have a couple of questions. One is, so are you happy with the pace of vaccination? Aren't we giving the virus a chance to mutate and find ways of escaping the vaccine-induced immunity?
Are you asking me?
Yes, sir.
Happy to see you, Vijay, in this group. I don't know, you joined IAP Calicut. Okay. Now, there is a phenomenon called, if you put immunity pressure, for example, against a mutating microbe, take Mycobacterium tuberculosis, for example. If you give one drug, the mutation rate is 1 per million. The mutated bacterium will overgrow the drug-sensitive bug, and then you will end up with all one drug-resistant organisms. If you have, let's say, 1 per million is a chance. If you give 2 drugs, then it will 1 million multiplied by 1 million. So there is a phenomenon of a pressure letting the mutating microbe to escape. So there are escape mutants. We have not seen escape mutants in polio, in measles, in rubella, in varicella, even in influenza. So that fear is unwanted right now. The variance of a single stranded RNA virus is routine. All single, you take vaccine derived polio virus. Can you imagine its mutation rate? It is so rapidly mutating. So all single stranded RNA viruses mutate rapidly. Even wild polio viruses mutate very much. You know how we know? If you take a wild polio virus in United States, they can pinpoint its geography of origin by the mutation fingerprint. So all of these viruses are mutating. Now in the coronavirus, the mutations, if a mutant variant has advantage over the previous one in R0, more infectivity, obviously that will spread faster and it will overtake all the other variants. Today, #1 variant in the world is our own product, Delta. So that is not due to immunity pressure. There is no evidence that immunity pressure will cause vaccine escape mutants emerging. Because the difference between bacterial and viral is the virus depends upon one receptor, ACE2. Okay, and if mutates too much, then it will be useless for, it will not infect human beings. So the mutations also have to be within a limited capacity. So I don't think that's going to be a problem. And I think we should immunize more reduce transmission to less, because what promotes mutation is free multiplication of the virus in the community. The more infection, transmission, the more chance of mutation. So that is all a myth. We must use more vaccination and suppress the force of transmission of the wild coronavirus.
One
Thank
question to, thank you, sir. One question to Dhanya. Dhanya, from Brazil data, the media data, you have suggested that we must try and vaccinate all the pregnant women as and when there is an opportunity. Now, we had a bit of confusion as far as lactating women. There was an advisory not to inoculate them, and then there was a clearance. But to translate it into actual vaccination of lactating women, it took more than a month. And even today, at some centers in India, the lactating women are denied vaccination. What would happen with pregnant ladies, and what is your recommendation with respect to timing of vaccination in pregnant women, first trimester, whether they can be vaccinated, what is the safety? And a second question with this vaccine question, maybe sir, I would want sir to comment is, would corona go the flu way, and will there be a requirement of an annual vaccine in future?
So coincidentally, we have just today written an article on prioritizing pregnant women for vaccination. Now, we all know that US, UK have allowed pregnant women to be vaccinated, and they have preferred the mRNA vaccine, which they have over 1 lakh pregnant women in US have already been inoculated with excellent safety record. Unfortunately, we do not have mRNA vaccine. Now, the UK Gynec Obstetrician Society has recommended Pfizer over AstraZeneca because of very rare but potentially serious life-threatening blood clotting risk. So now, with keeping all these aspects in mind, and the very fact that we don't have mRNA vaccine, and we should not delay protection of pregnant women, Covaxin seems to be a reasonably safer option for vaccinating our pregnant women. Regarding the timing, it has to be given as early as possible, because COVID can happen anytime during pregnancy, and we need 2 doses at least 4 weeks apart. National immunization schedule has your tetanus, diphtheria, toxoid vaccine given earliest in the pregnancy and one after 4 weeks. There's an option to give in the same visit on 2 different sites, or we can space 2 weeks apart as per what the pregnant woman would like. But these things should be under consideration, and I'm sure sir would like to comment on all these aspects, but this is how we can go about. Sir?
So safety
Yes,
first.
just to add, the phase 3 trials anywhere in the world, nowhere in the world, included pregnant women. So therefore, there was a question mark whether during pregnancy, can you give vaccine? And since there is no data of safety, they said, hey, hold on. Pregnant women were excluded from the vaccination in the early days. So in India, since pregnancy is not allowed, post-pregnancy lactating women was allowed because they are not pregnant anymore. So that is how it's a very, very odd way the recommendation came out that lactating women, yes, pregnant women, no. In the United States, because they found that there was adverse outcome of COVID in pregnant women, they began giving the mRNA vaccine, which is quite safe even for the fetus or for pregnant women. And so what Dhanya said that we wrote a paper is that we are a writing team. Dhanya and I write various articles in both in media and in scientific journals. So we have submitted a paper today, Tanya and I, by saying that pregnant women, anecdotally, we know all obstetric friends tell us that they are seeing death in pregnancy due to COVID, which they did not see in the first wave. Whether it is quantitative increase or qualitative increase, we will not know. The previous one was not infectious enough to infect everybody. And during the first wave, pregnant women were cocooned. We had an article saying that please postpone your pregnancy if you can. So all this might have helped to suppress the true pregnancy COVID problem in the first wave. The second wave, of course, the bottom fell apart. Whatever was going to happen is happening. So there's a lot of obstetric death. So vaccination is a must, but the government guidelines do not allow it. We have pushed Tamil Nadu government to write to the central government. They have written about 10 days ago, still no response. So today's submission by Dhanya and I is in the newspapers, again saying that the government should review its policy and to tell people that pregnant women should be vaccinated. I do not know whether obstetricians have the freedom to vaccinate pregnant women while there is the government advisory not to do so. I know of doctors who privately have asked me, got my okay, and vaccinated their daughters or wives or daughter-in-law with Covaxin during pregnancy.
Hiding the fact that they are pregnant. Yeah.
Thank you, sir.
Thank you so much, sir. And sir, final comment on whether it will be an annual vaccination in the future.
As you can see, even the third wave, I'm not going to predict. Similarly, I'm not going to predict whether it will be annual vaccination or not. However, what I boldly predicted in March 2020, when everybody said that herd immunity will kill this virus from existence, I had said, no, it will become endemic in all countries. And I coined the term pan-endemic. There is no word like that in epidemiology. Endemic, epidemic, pandemic. So I have coined the term pan-endemic. It will be endemic in all the countries, unless, of course, if it is eradicated. Will we need booster vaccinations periodically? Will depend upon whether we allow variants to emerge. Now, next variants are going to emerge in countries where vaccination level is very low. All African countries, we do not know which variants are coming. Even the immunity, or at least antibody immunity, is not long lasting. They're relatively short-lived. However, I have theorized that if you give an additional booster dose once, you will probably convert into lifelong immunity. All these have to be studied in future. So based on that, the Bharat Biotech is now giving a third dose and studying the immune boosting with third dose. If it goes very high, it will last longer. So yes, we have got to be prepared for annual vaccination like influenza. But if we reduce the transmission, the prevalence of variants will come down, and you may probably not need vaccination. But all the newcomers into society, children, will have to be vaccinated until
one question, Ajay,
eradicated.
One question I want to ask. Sir, I'm Dr. Shashidharan. Now the point is, we are confronted with vaccine hesitancy. We are confronted with delayed vaccination. And we are confronted with COVID infections in vaccinated people. And also we're confronted with the mutation in the virus. Where are we heading for? I think I need an answer from Jacob Johnson.
Where are we headed for is a rather vague question. Each one of these problems that you listed are solvable problems. Okay. For example, supposing a nasal vaccine comes up and the nasal vaccine can be given as drops, there is no reason why this virus can be eradicated. Okay. So Dhanya and I are advocating eradication through WHO, and we are getting some signals saying that they're not very keen to do so now. They're defending rather than telling us it cannot be done. So we do not know the future exactly. This is an unprecedented virus. So we'll have to be very cautious. Prediction should be caution-based, but constant observation, research, and investigations are important for both these questions: annual vaccination and what can we expect in the future.
Yes, sir. There's a question from Dr. Anand, sir, regarding the ACE2 receptors which you're telling. Like we have different infectivity in first and second wave. Is it due to mutant strains bypassing ACE2 receptors or something else?
If the virus cannot hit ACE2, it will not infect people. Finished. The virus is dead. So virus will not mutate enough to escape from ACE2 into some other receptor. No, this virus cannot mutate and select another receptor. So ACE2 is fixed for this virus.
Dr. Ajay?
Yeah. A very excellent talk, sir. Just a few questions from Dr. Jacob John, sir. One thing is transmission we can prevent by vaccination. But we know that vaccination available in India will give only systemic immunity, no mucosal immunity. So those who are vaccinated, they still can transmit because there is no mucosal immunity. So to have mucosal immunity, we should have a nasal vaccine, which not only nasal vaccine, but it should be replicating also, because non-replicating virus will not produce systemic side antibodies. So we want a live attenuated replicating virus nasal vaccine, which will be the ideal. So what will be your comment regarding the prevention of transmission through vaccination?
If Ajay Arora owned
Yes.
a vaccine manufacturing company, we know which direction he will go for making a vaccine. But let me tell you that asymptomatic people and symptomatic people, who transmits more frequently? Symptomatic people. Why? Their virus load is higher. Therefore, they throw more virus outside. So what vaccination does is to reduce the severity of COVID down a gradient, and in parallel, the virus load also is coming down. So Vijay talked about, anyway, about the Israeli experience, that with vaccination, the incidence of infection is coming down. So when you protect people with vaccine, they tend to have asymptomatic infection more than symptomatic infection. Therefore, less virus load, less duration of virus shedding. So the R less than 1 is going to bring down transmission even steeper than natural R less than 1. So vaccination, if you do it right and have high coverage, it can actually interrupt transmission. Today, which countries do not have any poliovirus? Only those countries that use IPV. Same principles. IPV reduces the transmissibility of infected people, duration, and the intensity. Therefore, it's a cascade down. Over a period of time, even with immunity, without any mucosal immunity, Haemophilus influenzae injected vaccine, pneumococcal injected vaccine, whooping cough injected vaccine, diphtheria injected vaccine, all of them, typhoid fever injected vaccine, all of them have what we call herd protective effect, that if you increase the coverage, the incidence comes down. You can even eliminate any of these if you want to.
But sir, in pneumonia, we know that in nasal carrier, there's a change in serotypes. So there is an effect on the nasal cavity also. So similarly, you, according to you, it will affect your immunity to such extent that after some time, that virus becomes the seasonal virus, like influenza H1N1.
Yeah, the nasal carriage is peculiar to pneumococcus and Haemophilus influenzae. So when a child gets pneumonia, it is an endogenous infection mostly, and not exogenous infection. Okay, the second question, will it be, it will be endemic. Will there be seasonal ups or down? For influenza, there is. For COVID, probably not. Because hot countries, hot weather, cold weather, the virus is sweeping through irrespective of the climatic conditions. So my guess is that there will be not much of seasonality, but a fairly steady endemicity. All right.
Thank you, sir. Thank you, sir.
Dr. Siddharth.
So good evening. This is Dr. Siddharth here, Siddharth Basak from Siliguri IIT. And good evening to ma'am, also Dana ma'am. I was just curious regarding, like, suppose a lady who has been got infected in the month of December or Jan conceives later on. I'm asking this because I have my sister who is right now pregnant. She has this. She got, and after that she recovered. She was, you can say, she had mild symptoms and all. Now she's pregnant right now. So, what is the probability of her getting? What is the probability of reinfection to her? And how long can we assume that since she got a natural infection, she would be protected because of the natural antibodies that she has acquired? And what is the latest update regarding the, you can say, the configuration of this obs-gynae gynae as to when a pregnant lady is supposed to be vaccinated? And as you said, a few of your friends, they got vaccinated for vaccine. How did they manage it? I was just curious to know, sir. Thank you, sir.
If I understand the question correctly, a woman got infected in a particular month and became pregnant a month later. Is that the
right, sir?
Okay.
Right, sir. Right, sir. Right.
Okay, no problem, because when she got pregnant, she would have recovered from the infection or
right,
well on the way to recovery. That is not the time when you have severe COVID. So pre-pregnancy COVID is just like COVID in that age group. Younger the age group, that's the problem. The issue of pregnancy is, in spite of the woman being young, 18, 20, 25, 30, and in all the peers without pregnancy, very low severe COVID, very low mortality. Pregnancy by itself is like diabetes, chronic kidney, heart, lung disease. As I cannot call it comorbidity, but a condition that predisposes a normal person, otherwise not at risk of high probability of severe COVID, pushed into severe COVID. We do not know exactly the physiological reason, but we know that H1N1 can be fatal during pregnancy. Okay, so there are some pregnancy-related issues of infectious diseases Very few infectious diseases are made worse during pregnancy. H1N1 is COVID days.
And so, how much do you feel that a natural infection will be protecting her? The natural antibodies which she has acquired because of the infection. How long would she be under protection because of? Is there any data related to as that a person who is naturally infected doesn't get reinfected, whether it be pregnancy or whether it be any other comorbidity there?
Natural infection is a good immunizing experience. However, even that, the decline of immunity, particularly antibody levels, is a bit disappointingly too much. At 2 to 6 months later, some of them would have not measurable antibody levels. Same as post-vaccination immunity. So therefore, a small proportion of people have been observed to get reinfected. By and large, reinfection is milder than whatever happened in the first infection, but not always. All right.
Thank you so much, sir. Thank you so much.
Thank you, sir. So one question to Dr. Danya. Ma'am, this regarding the multi-system inflammatory syndrome. So what to do if they present on the first or second day of fever, probably, and doesn't fit fully into the WHO criteria, but there is some clinical and lab indications that it could be MIC. Should we start treating these children? That is one question. And second question is, do all the MIC children need both IVIG and steroids, or you can just get away with steroids?
Actually, even if they present on day 2, and if the child is not exactly showing all the symptoms which are fitting, then you'll have to rule out also the other causes of fever like rickettsia. They all have this fever, rash, dengue. So because monsoon is coming up, there'll be many overlapping infections. So in children who are hemodynamically stable, have mild condition, you need to first rule out any underlying problem which could be contributing to that disease rather than starting treatment. Now, regarding the child who is critical, regarding IVIG and steroids, so but there are few publications talking about they have used just steroids, but what is ideally recommended is IVIG and steroid for a successful treatment, because the severe myocarditis and MIC. The protocol is under revision, and there's a lot of brainstorming going on the protocol, and it will be released in few days. So we'll have to just wait for a few days more until all the rheumatologists and intensivists, they are at present discussing how to go about, because we are aware that IVIG is not very easy to get, but that's how that is what all the international and ideal protocols talk about. You must use IVIG.
Sir, I think because of time constraint, we'll try to cut down the questions a bit. Maybe I will take one last question, sir. So, question from Dr. Geeta regarding, we have seen a large number of breakthrough infections among healthcare workers during the second wave, even though after 2 doses of vaccine. So, will this be the same way during the third wave? What is your prediction, sir?
Yeah, the problem of that is truly breakthrough infection after 2 doses is not a universal experience. There's something odd in India. Is it the quality of vaccine, or is the infection inoculum is too high in our healthcare settings, so that doctors get inoculated with a unnaturally high dose of virus? We do not know. All these are actually should be subject for scientific studies. But unfortunately, India, we theoretically talk, who is in charge of research, where is the money. If somebody wants to do a research on this thing, the application will take 1 year before it is approved. Then money will come another 6 months later. No, we are not geared for timely research. And there are, clinicians are so busy looking after sick patients. They're overworked. They don't have time for research. So we like to live with incomplete data. And so many of these questions will never be answered. I'm also worried about the kind of anecdotes I hear, people dying of COVID in spite of taking vaccine. I am kind of, nonplussed. I do not know how to console the family who have taken somebody who has taken 2 doses and then dies. Peculiarly, I don't think I should say it in a group like this. It seems to be directed at one vaccine and not both vaccines. But I do not know for sure.
Yeah.
There was one question that's a flash. I will answer that, although you said it last question. Covishield is allowed for foreign travel. Covaxin is not. The question was why. Covishield is an international vaccine. The reason why we have approval for travel for that is because it is approved in other countries. We keep backing on other countries' approval, and therefore Covishield is another name for AstraZeneca vaccine. Different countries, different geographies, there are different names. So it is the same vaccine that has got WHO approval for international use. Therefore, if you take that, you have approval for foreign travel. Covaxin is not an Indian vaccine. It's a private company's vaccine. India never did anything to make that vaccine, except they requested, and ICMR gave one strain of virus to them. Not one. They gave 3, of which they chose 1. So there is nobody to push the Covaxin through to the WHO and get approval, etc., etc. I checked with the company, and they said they are in the process of completing the dossier to apply to WHO for approval as a standard vaccine, so that if you take that, you can travel. So when I asked the company, they turned back to me and said, will you give us a independent clinical assessment document? So I've just sent it to them. The company by itself applied to FDA for emergency use authorization. FDA turned it down because WHO has not approved it. WHO has not even looked at the dossier. The dossier is not with them. There is no godfather for Covaxin in the country. ICMR is not, Government of India is not, Ministry of Health is not, Prime Minister is not. So it's a private company's vaccine, and they have to do everything by themselves. So they are now preparing the dossier for approval from WHO for emergency use approval by WHO. The moment that comes through, you can travel with Covaxin certification. It's a very, very, very complex and disappointing scenario in India.
Thank you, sir.
ഒരു basic.
So, hello.
അതൊരു ബേസിക് സയൻസും ഇതൊക്കെ അറിയുന്ന പ്രൈമറി.
Hello, Mohandas.
Hello. So we have it's a long time had a lengthy discussion, and I think participants from all over India were present in this. I would like to invite Dr. Ajay, Secretary, IAP Calicut branch, to say 4 times.
Thank you, sir. So it's a great privilege to have Dr. Jacob John, sir, and Dr. Danya for our COVID webinar, mostly on third wave, and it's indeed reassuring to know from him with scientific evidence what to go and why, how much we should be worried about the third wave and other things. So thank you, sir, for accepting our invitation and coming for the talk. Thank you, sir. So also Dr. Danya, so ma'am, thank you for accepting our invitation and coming to IAP Kozhikode for giving your talk, ma'am. Also, would like to thank Dr. C.K. Shashian sir, a senior consultant and past HOD, previous HOD of Government Medical College Kozhikode, for your excellent moderation, sir. Thank you, sir. Lastly, I would like to thank all the participants for your patient listening and your valuable inputs and discussions. Thank you, everyone.
Thank you. Good night, everybody.
Good night, sir.
Good night.
Thank you.
I'm leaving. All right.